Hello, my name is Brenda Kirk, and I'm here today to teach you about how to position, or a little bit about, I guess, the forearm and elbow and how to position for an x-ray of those two body parts. A couple of things I want to go over first are just a very simple definition because sometimes they can be confusing to people, especially when you're first learning about positioning and taking x-rays. A position is just the specific placement of the body part in relation to the radiographic table or its image receptor or IR during the image. Now, projection is the path of the central ray as the X-ray tube and goes through the patient to the image receptor. So the position is the placement of the body. The projection is the central where the central ray is going while you're taking the image. And then a true projection is the body part is placed exactly in the anatomical position. And a lateral projection is where the central ray enters one side of the body versus the true projection. An oblique is the center enters the body at a slight angle, which we call oblique. And a view is used to describe the body part as seen by the IR. So to begin with, I'm going to talk a little bit about the positioning of the forearm. It's real important when you position anything in radiology that you collimate down to just what you need to see, but not that you collimate so much that you cut off essential parts of what you're trying to do. So for your forearm, we'll discuss a little later, but you want to make sure you include both joints, the wrist and, the elbow joint in every projection in both AP and lateral. You want the patient needs to be seated because you're going to get able to get the humerus and lower to the film, which is better positioning. So what you'll do is on the AP, you extend the arm out as much as you can with the palm facing up. And remember that we're including both joints. It's done tabletop. Your central ray is perpendicular to the film and centered mid-shaft. You use 40-inch source image. Lateral, your arm should be positioned so that it forms a 90-degree angle with the humerus, and the hand and wrist are in a true lateral position with the thumb up. Now both the humerus and the forearm should make contact with the image receptor. Whether it be film or a digital cassette, that image receptor could be either thing. It's also done tabletop, 40-inch SID, and the central ray perpendicular to film mid-shaft. Now, here is some perfect x-rays of what you would, this is what we all should aim for when we're trying to get an x-ray. And it's important, this is the two joints. You see the carpal bones. We're not going to, since we're not doing a wrist, we're not going to go over what they all are, but that you just have them on here. When you study wrist, you'll understand what those are more. And that you have the elbow included as well, because here's your second joint. You'll see here's the ulna and the radius. Radial neck, head, olecranon process, this little square piece in here. We're going to look at that a little more later to see a better picture of it. Ulna head, styloid process, and styloid process of the radius. On the lateral, a true lateral, you're going to see here where it's not rotated, it's just perfectly straight throughout. There's your two joints again, and your other joint down here. The olecranon process on this side, ulna radius. And they're really nicely visualized down here so that you can see it with very little superimposition. You don't always have a little bit just because of the way the body's made there. But for the most part, you're going to be able to see it really well if you have a good true lateral. Elbow position. The same thing. Collimation is important so that you're not overexposing the patient any more than what's necessary. Patient seated again, the palm up, arm truly extended out, laying as flat as you can get it. There are some times that you can't get the patient completely flat, and there's some tricks to doing that where you can use a little angles on the film or the arm and still get a decent picture, but always best to be as flat as you can when you do that. Both AP and lateral are both tabletop, 40-inch SID, and your central ray this time is to the center of the joint, which basically is your center of your elbow. Once again, the lateral is done very, very similar to the, almost identical to the way you would do a forearm, except you would center it, collimate it down to your elbow. And the AP view, I'm sorry, lateral view is where it demonstrates the electron process very well. Now, the elbow is a type of joint, and it's a hinge joint with synovial fluid, so that permits only flexion and extension. And it's similar to the way the knee and the ankle also work. And here is a picture of the electron process where you can kind of see what it's supposed to look like. I've just got these pictures here to highlight the trochlea, the capitellum, the head of the radius, trochlear notch, so that you can just see them a little better with the colors. Okay, here are some images. Perfect images once again of the elbow. You can see nicely here the electron process, the joint space. You see by supinating the elbow and make sure the palm's up, you get to see both the radius and the ulna very well, all the way through down the shaft. And here's your humerus. You've got the lateral epicondyle ridge and lateral epicondyle, which is the outer side of your arm. And then the medial would be the inner side or the thumb side of your elbow. So we've got the medial supracondylar ridge and the medial epicondyle. Okay. Sorry, we were talking about it. Okay. Now, I've included the oblique view. Not that we're learning about the oblique view today. We're just here to learn AP and lateral. But I wanted to include this because many times you see people turn something like this in. Technologists will turn this in and call that an AP, but it really isn't a true AP view because you do see things a little differently than you do on this view over here, and you can tell that it's off, and you would miss like the trochlea. You don't see it as well over here as you do on this side. It changes the way your spacing looks. It shifts your electron process where it's a little distorted. But it does open up the electron process. So there's good benefits to this as well, and not just this. And especially if you were trying to look here at the stylus, you would be able to see it better and see the space between the elbow for obliques, and that's one of the things that makes it important. But most of the time, your AP and your elbow, the type of fractures that people get from elbows, you can view them on those two views, and sometimes your orthopedic surgeons will ask for these more special views. So once again, you can tell this is a very perfect lateral because it lines up so good here. In the supracondylar ridge that we talked about over here, you can see it nicely on the edge, but here you really get to see a better view of it, and it's just a pretty picture. Once again, your ulna and your radius, electron process, get another side of it, a different way to look at it, and then the notch here, humerus shaft. So now that we kind of went over the anatomy a little bit, this is how it's all done. So we're always talking about making sure that your hands up, your humerus, your forearm laying as flat as they can on this plate. Now this is a cassette, but you would work the same way for any type of imager software you use, a digital plate or whatever CR you're using. Now over here, if you'll notice, this arm's not laying as flat, and really you want to get that down just as much as you can. So sometimes you have to actually have the patient lean one way or the other, or squat down, maybe a lower chair, whatever you need to do to be able to get it just as flat as you can, because you'll get a better image. On your lateral, same thing, this nice 90 degrees here, thumbs up. You can tell this is probably the thumb right here, and it's up mid shaft for central ray. Over here, now for me this looks a little tight, but you may not get both joints, and I would use a little bit more, open that collimator up a little bit, maybe a larger film on this, like they've done over here, because I think it's important that you make sure you get both joints, because it's more important to get it the first time and not have to repeat the patient. And here your elbow is central ray, mid joint. These are just some more examples, different ways people do them. And you can collimate it down to really small films if you want to. This here is an example of a patient that couldn't bring their arm all the way down, so you may have to do things just a little bit different. Over here, the fat pad of the elbow. Let me tell you a little bit about that fat pad. It's a lucency that represents a fat and is present along the anterior surface of the distal humerus. and no lucency is visualized along its posterior surface. Now, when you see that it's elevated, that can be a sign, what's called a positive fat pad, and that can be very important in diagnosing a fracture, because if an elbow is in a true 90 degrees flexion, then it would be a positive one, but many times you get a false negative fat pad sign because of poor positioning. So it's a great sign, but really important that positioning is done right. Let's see. So back to our criteria, and that's how we know that we do positioning correct or not, is by the criteria. Again, both joints are very important, and we're looking at the forearm, elbow. It doesn't. I'm sorry, only the forearm would be both joints. On the no rotations, when we talked about the laterals or the APs, either one, because it's going to distort it, make it look like an oblique. Open elbow joint. So that joint that we looked at earlier, we want to make sure that that is also open. That's a good sign that you've done a good x-ray of the forearm. On your lateral, make sure there's no rotations, that the ulna and radius line up well. Your elbows flex 90 degrees, and the soft tissues are visible. So you don't ever want to shoot the x-ray so much that you burn out the bone and stuff, and you can't see the soft tissue. Your elbow, kind of a lot of it's the same, except obviously you're not going to have both joints. You'll have a proximal radius, ulna, and a distal humerus. But rotation is always important. Your lateral elbow, make sure that you've got your proximal forearm, your open joint space, your 90 degrees, that your superimposed humeral epicondyles. You're looking for that true lateral and those fat pads, and to make sure that your positioning is so important on that. Okay. Collimation. You reduce the amount of tissue that you radiate, reduces the amount of scatter produced. It helps in your contrast, and it reduces dose to the patient. As far as quality, and all of this is about quality imaging, because that's what our goal is to turn in a diagnostic exam. So you want to look at your density, your contrast, your spatial resolution, your distortion. Your density amount is your amount of blackness on processed radiograph, and your optimum contrast allows for anatomic detail on a radiographic image to be visualized. These were just some cool pictures. I wanted to show you that, not cool for the patients, obviously, but this is a complete break of the radius. Over here is the break on the ulna, and then a really bad dislocated elbow. Oops, sorry. So, that's it. And I hope y'all enjoyed this, and that you learned something that you didn't already know about how to do a forearm and a humerus. A forearm and an elbow. Thank you.